I'm Yuji Ishino from Kanazawa, Japan. We have no COI. Massive intraoperative blood loss, IBL, is one of the major complications in metastatic spinal tumor surgery. Some papers have reported risk factors for IBL, including hypervascular tumor type. And we have experienced massive IBL from intratumoral blood vessels in palliative excisional surgery. So we have focused on intratumoral phloboid. This sign is hyperintense and tubular lesion on standard MRI, and this sign indicates blood vessels. The phloboid has been reported in metastatic bone tumors of limbs. However, there are few reports in the spine, so we hypothesize that intratumoral phloboid that indicates tumor vascularity may be associated with IBL in metastatic spinal tumor surgery. So we investigated the association between these two factors. We retrospectively reviewed 93 consecutive patients who underwent palliative excisional surgery for metastatic spinal tumors from 2010 to 2024. We excluded the cases with a tumor excision, and we assessed factors associated with IBL using univariate and multivariate analysis. We examined these demographic and surgical factors, and renal cell, hepatocellular, and thyroid carcinoma were defined as hypervascular tumor type. In radiographic factors, we examined the presence of phloboid on standard MRI and diameter of phloboid. MRI images were taken in 3 planes with T1, T2 SLR images by 2 spine surgeons. The diameter of phloboid was defined as the greatest vertical distance across its tubular structure. Results. The average IBL was 408 milliliter. The presence of phloboid was 79%. The average diameter of phloboid was 1.8 millimeter. The IBL progressively increased when we segmented diameter of phloboid at 1 millimeter intervals. In univariate analysis, factors associated with IBL were number of instrumented vertebrae and resected vertebrae, surgical time, hypervascular tumor types, and the presence of phloboid and diameter of phloboid. In multivariate analysis, rated factors associated with IBL were surgical time and diameter of phloboid. This is a representative case of T12 metastasis of germ cell tumor that is non-hypervascular tumor type in an anterior mediastinum. This patient exhibited paraplegia of flanker sheath and emergently underwent posterior decompression and fixation. But preoperative MRI shows large phloboid like this, with diameter of 3.7 millimeter. During the excision of tumor on the left side of T12, there was massive blood bleeding like this from intratumoral blood vessels. Hemostasis was too difficult even with the use of hemostatic agents. We managed to control bleeding like this by compressing GERDs for over 30 minutes, 4 times. But the IBL was 2,150 milliliter. Discussion. No reports about the association between intratumoral phloboid and IBL in metastatic spinal tumor surgery. This association indicates large phloboid, indicates intratumoral blood vessels that are hard to control in bleeding. Some papers have reported hypervascular tumor type is a risk factor for massive IBL. However, in this study, intratumoral phloboid was associated with IBL in multivariate analysis. Metastatic spinal tumors with hypervascular tumor type can be classified as non-hypervascular through angiographic assessment. Therefore, intratumoral phloboid can more directly reflect the vascularity of metastatic spinal tumors. Conclusion. Intratumoral phloboid on MRI was associated with IBL in palliative excisional surgery for metastatic spinal tumors. Large phloboid indicates hypervascular tumor with intratumoral blood vessels. Thank you.